So this is, I don't know how many of you have seen such a patient. So this is how the patient with TM joint, when you ask them to open the mouth, they may open the lips widely, but the inter-incisor distance will be totally absent. It cannot be opened at all. So it will have the clinical presentation will be restricted mouth opening, dentofacial deformity, poor oral hygiene, dental caries, and impaired speech, sometimes difficulty in mastication, so they may have malnutrition. And if they have a very short jaw, maybe micronanthia, they may have OSA features also. And bilateral, they usually have micronanthia and retrornanthia. So this will be the appearance of the mandible in the bilateral cases, which is called the bird species. Looks like the face of a bird. So this is called the bird face deformity with a small receding mandible with a steep occlusion plane, and the oropharyngeal airway is very much narrowed, secondary to shortening of the mandible, the rami and narrowing. These sort of cases may be difficult even for fiber optic intubation. Okay? So that is the main reason. If this child has a better mandibular growth, whereas this child has a very receding short mandible, so fiber optic intubation might be more challenging in these patients. So the clinical indicator of severity is the interincisors are opening, and less than 5 is termed as the complete ankylosis. The types, of course, there are several types, which is not necessary. And this is the orthopantogram, which is normally taken to find out. You can see literally all the upper jaw teeth are touching in the lower jaw without any mouth opening. So this is a CT scan showing the TM joint ankylosis. This is the reconstructed. Now the objectives of surgical treatment are release that main thing, release the ankylosis so that mouth opening can be adequate, improve mandibular function, and maintain normal growth and development of the face. Otherwise, the face will be in a disfigured fashion. So these are the three important aims of the surgery. So the surgeries that are available or done usually are gap arthroplasty, interposition arthroplasty, and excision of the ankylotic mass. And the incision is made usually in the pre-auricular approach and temporal extension. These are the pictures I have just showing for the benefit of those who have not had a chance to see that. See, this is called the question mark incision. Usually it is made on the temporal region to the pre-auricular region, and the whole area will be exposed, and the fused temporomandibular joint will be exposed, and then they will break that bone. And nowadays we have implants which are available which will be inserted like a normal joint. It can function. So just like your knee replacement or shoulder joint replacement, nowadays we have titanium TM joint processes are available which can be implemented. And from this limited mouth opening, this is considered as a nice successful release with a good mouth opening of a normal size. So this is what we want to aim, so that the patient will have a ability to masticate and chew well and eat well, and the facial appearance will also become normal. So that is the purpose of the whole surgery. Now the challenges in this particular case are this patient has a management of pediatric patient, 5-year-old baby or a boy, and he may not be cooperative. So and second part is the anticipated difficult airway scenario. So these are the two challenges that you have. So how are you going to manage this? The difficulty in intubation is because of the trismus and patient's uncooperative nature, and because of the psychological problem of being taken to several physician doctors, the patient may also have some neurobehavioral problem which will add to the uncooperative nature of the child. And what is the anesthesia of choice, and what is the pre-op preparations required? Anesthesia of choice is GA with ET tube, either in the normal nasal route or by the tracheostomy. So before that, if the patient has not been able to eat properly, you must assess the nutrition and improve the nutrition. Correct anemia is present, and prepare the oral cavity by asking them to gargle with antiseptic so that oral hygiene will improve. Remove any loose or carious tooth, and then make a pre-op visit. Being a 5-year-old child, you can always talk to them and try to develop a rapport with the patient. And you can use MLA cream for securing the IV line, and also reserve compatible blood, because sometimes when they try to remove the fused bone, the pterygoid plexus of veins may get injured and there may be massive bleeding. So it is better always to reserve blood. You need not bring it to the OT, but it should be available on call. And the methods of intubation: blind nasal intubation in a child only after adequate sedation can be done, fiber optic nasal intubation, retrograde intubation, and lastly, if nothing succeeds, you have to go for tracheostomy or elective tracheostomy has to be done. And deep sedation or general anesthesia is needed to carry out any of these things. So how to sedate the patient for this procedure? First thing is always keep an experienced anesthetist and ENT surgeon by the side before starting. This is the important point that you have to mention in your both practical exam if this case is kept, or in your theory answer also, because this is a life-saving thing. Sometimes we can land up with a inability to interpret and inability to ventilate. The patient goes into sudden laryngospasm and he is not able to breathe, and you are not able to put the tube also. So it is always better to keep experienced people with you. Then secure IV access, connect all monitors, check for suction, check the functioning suction, keep front of neck access kit ready. That is any brachydactyly sit or the tracheostomy sit be ready. Give glycopyrrolate 20 mics per kg, because in a closed mouth suction will be difficult if secretions happen. So better to dry up the suction area of pharynx, and sedate with midazolam 0.1 milligram. Then give propofol 1 milligram per kg, and or remifentanil infusion 0.1 mic per kg. Then topicalize the airway with 4% lignocaine. Then always preserve the spontaneous respiration, and then go for any of these things. Either normally fiber optic nasotracheal intubation should be successful, so you can go for that with the commonest, easiest method. So these are all the steps how you do that. So the exam also they will ask you how will you sedate the child. These are all the steps that you have to follow exam. Okay.
Yes, sir.
For this particular question. Right.